topic today I'm going to present is about the factors to consider for prescription writing. And the aim of the presentation is to make the audience understand about the different types of refractive errors and the factors to be considered while prescribing. So this is the summary which I'm going to explain in the upcoming slides. So hyperopia, so everyone knows it's a farsightedness in the light rays fall behind the retina, and when the ocular accommodation is completely in a state of relaxation. So what is latent hyperopia? So if a person wants to see a near object clearly, he accommodates. That is, the ciliary muscle constricts and the ligaments relaxes and the lens becomes bulges. So this process is known as accommodation. So even though when the patient is not accommodating, there will be some tone in the ciliary muscle. That tone is known as inherent tone of ciliary muscle of up to 1 diopter. So it varies according to the age. For younger age, that tone will be greater, whereas the age increases, that tone will get reduced. So this is known as latent hyperopia. So how it can be revealed? It can be revealed with the help of cycloplegic refraction. So then what is manifest refraction? It is revealed while doing the objective refraction. Sorry, what is manifest hyperopia? It is revealed while doing the objective refraction. So total hyperopia is equal to latent plus manifest hyperopia. So what is physiological hyperopia? So hyperopia up to +4 diopter at birth and up to +3.5 diopter at 8 months and +2 diopter at 1 year is considered physiological. And according to the American Optometry Association, this is how the hyperopia was graded, and high hyperopia is considered as greater than +5 diopter. So prescribing considerations. When we are dealing with the hyperopic patients, these were the factors needs to be considered: the age of the patient, whether they are presbyopic or pre-presbyopic, severity of the symptoms, degree of hyperopia, whether they are having active accommodation status or not, and how bad the visual acuity is affected, whether the patients are amblyop or not, and efficiency in performing visual acuity tasks related to their occupation needs. So children from infancy to 10 years old. If an infant has a good amount of visual acuity, good stereopsis, and doesn't have any kind of strabismus, and if the hyperopia values they are getting is less than +3 diopter, it's better to monitor, because the emmetropization process typically reduces the hyperopia. But in case if the child is having amblyopia or strabismic esotropia, it's better to give full correction. So generally, what will the approach we can go for in hyperopic patients in early adults who doesn't have any kind of strabismus or any kind of amblyopia? So the cycloplegic refraction reveals +3 diopter. So we need to slowly defog the lenses until the patient from +3 diopter until the patient achieves clear 6/6 vision. And also diachrome refinement is necessary to make the balancing the red and green, or try at least red is clearer than the green. So pre-presbyopia. So presbyopia usually begins after 40 years of the age. So pre-presbyopia occurs between the age of 35 to 40 years of the age. So the patient would be having difficulty to look at the near working distances. So it occurs due to diminution in the accommodative power. So what were the measurements that are mandatory while dealing with pre-presbyopic patients? Accommodative amplitude and accommodative response should be documented. And for correction purpose, if the patient was undercorrected at the distance and if the patient is hyperopic, we can push the plus power as much as possible without affecting the distance vision, so that the patient will be comfortable for the near also. But in case if the patient is having a lower amount of hyperopia at the distance, even though after pushing the plus power the patient was not comfortable for near, it's better to consider lower add based on the patient's professional needs. And also it's needed to repeat the accommodative amplitude and accommodative response once again once the procedure is completed. We need to mention how much of accommodative amplitude was improved post giving the add, and whether the accommodative response, the lag was maintained instead of going to the lead. If it becomes lead, it shows that patient was accommodating excessively. So let's see a case presentation related to the pre-presbyopia. So the complaint of headache and blurring of vision for the past 1 year, so 37 years old. So the previous glass prescription, the patient was wearing +0.75 diopter for more than 2 years. So with glasses, the patient has a good distance vision but reduced near vision. The retinoscopy values which we got was +2.5 in the right eye and +3 in the left eye with the -0.75 cylindrical, whereas the patient was accepting up to +1.75 and +2.25 with -5 cylindrical at 90. So the distance vision was unaffected and the near vision was improved, and also the refining procedures diachrome was balanced. So how we will determine the occupation related power? So if a person, a 60 years old male computer profession working at a distance of 65 centimeter, and if he is noticing blur vision, we can determine that power by measuring the working distance from the eye to the working level the patient needs. So let's take a example. Two examples. If a person is working at a 40 centimeter distance, do the reciprocal of that working distance. So 100 by 40 is 2.5 diopter. So for 65 centimeter, 100 by 65 is 1.5 diopter. This is the amount of power the patient needs to look clearly. So all may be thinking if the patient is 60 years old, he would be already wearing plus 2.5 or 2.75 diopter of add. So how we can incorporate this plus 1.5 add? In these cases, we can go for progressive lenses. It will give a intermediate vision also. So myopia. So myopia is like all would be familiar when the rays fall in front of the retina and the ocular accommodation is relaxed, and it's also called as nearsightedness. So according to the IMI, this is how the myopia was classified. If the patient is having greater than minus 0.5 diopter, is considered as myopia onset. And if the myopia is of greater than minus 0.5 and less than minus 6 diopter in the ocular accommodation is relaxed, we consider as low myopia. And it is greater than or equal to minus 6 diopter when the ocular accommodation is relaxed, it's considered as high myopia. So what is pre-myopia then? So if a children, like usually age between 8 to 9 years of the age, 6 to 9 years of the age, they are not showing any kind of hyperopic prescription to their age norm values, and they are showing low hyperopia or they are showing the myopia onset in those cases, it's considered as pre-myopia. Those children were very much prone to become high myopic in the next future years. So prescribing considerations for myopia. Don't never undercorrect or overcorrect myopia. It's always go for optimal prescription based on the cycloplegic refraction. So in a clinic, generally, if we are noticing any child whose myopia was progressing for every 6 months up to minus 0.5 diopter, it's better to give additional instructions like follow the 20-20 rule and a minimum of at least 2 hours of outdoor activities. That means sun exposure is needed, and promote early to the bedtime. And screen time advised to completely restrict the mobile phone activities or reduce the screen time activities. Let's see a case example. The child age 11 years complained of blurring of vision for past 6 months. So the child was wearing a refractive correction of minus 3, minus 1 to 180 in the right eye and minus 3.5, minus 180 in the left eye for more than 1 year. And we can see the distance vision was reduced. So while doing refraction, we are getting minus 4.5, minus 1.5 at 180, and similarly minus 4.5, 1.5 at 180 in the left eye. Whereas the cycloplegic refraction reveals minus 4 in both right and left eye, a similar amount of cylindrical power. So in these cases, we can go with the cycloplegic refraction value. So the patient was comfortable with the cycloplegic refraction and the vision was noted as 6.6, and the duochrome was also balanced along with the JCC refining procedure, and fogging should also be done. So let's go into variant myopia. What is variant myopia? If there is a discrepancy between the objective and subjective refraction with a greater than 1 diopter without any presence of accommodative dysfunctions, like not any kind of spasm or anything, but it shows a discrepancy between the objective and subjective refraction, it is said as variant myopia. So one of the potential reason for this could be off-axis retinoscopy. That is, it can induce significant spherical or cylindrical errors due to small degree of eccentricity. How it can be controlled? By maintaining the same eye level between the patient and the examiner, and also adjust the trial frame according to the IPD, and do the right to right and left to left objective refraction. That means patient's right eye and examiner's right eye, and patient's left eye and examiner's left eye. And also it's better to document the axial length, K value, and autorefractometer readings in such cases. Let's see a case example for this. Let's consider a patient aged 24 years old and came for refractive surgery opinion. So the patient was wearing a glass prescription of up to minus 8.5, minus 1 cylinder at 180, and minus 9 and minus 1 cylinder at 180. He or she was wearing for more than 2 years, and they are comfortable with the glasses and vision was good. And while doing a refraction, we are getting more than 1 to 2 diopter difference in both right and left eyes, and the cycloplegic refraction also reveals the same. Whereas with that power, the patient's acceptance was reduced. From 6.6, it became to 6.12 and 6.18. The patient was accepting the same power which she was wearing, or she was already wearing. So in these cases, it's better to document the axial length, because with the axial length, we can correlate the refractive error. We all know that 1 mm increase in the axial length causes 3 diopter of myopia. So we can correlate the myopic glass prescription with the axial length value. So astigmatism. So even a small changes in the power in the astigmatism, patient will be very symptomatic. So it's better to do the proper refinement procedures and objective and subjective methods. And always take the account of patient's age, visual needs, working environment when prescribing, and also the print size and working distances. Like in case if the patient has a high magnitude of astigmatism and he was treating for the first time, detected after the age of 35 years, it is advisable to give partial cylinder correction at the first and progressively increase the strength in the following upcoming follow-ups. So amblyopia. So a unilateral, let's see the definition of it. A unilateral or bilateral decrease of visual acuity caused by pattern or abnormal binocular interaction between two eyes. So if the difference is greater than 2 lines between the eyes or less than 6.9 visual acuity, is considered as amblyopia. So how the prescribing pattern should be. Full correction is always necessary in amblyopic patients, whether it's anisometrope or strabismic, in order to achieve the better visual correction. But in case if the patient is experiencing diplopia due to the full correction, we can go for contact lenses or prism corrections over the refractive error in order to avoid the diplopia. So in case of anisometropia, who doesn't want full correction, either because of the cosmetic concerns or due to the diplopia factor? In those cases, we need to balance the refractive error between the both eyes. If the eye is having a difference that exceeds greater than 4 diopter, the patient can appreciate diplopia. And also, it's better to recheck once with the Worth-for-dot test whether the patient was maintaining the binocular single vision or not. So, what are the measurements to be considered while prescribing spectacles? Interpupillary distance. So it is measured. It is a measurement between the center of the pupil. It is necessary to check the alignment within your eyes while prescribing glasses. It can be measured with the help of ruler or pupillometer. Segment height, and it is essential. It is necessary for the patients who are wearing bifocals and progressive lenses. So for bifocals, it can be measured from the lower eyelid crease, and for progressives, it should be measured from the center of the pupil. So why it is necessary? Because segment height refers to the point where the additional magnification for near vision begins. So vertex distance is the distance between the front surface of the cornea to the back surface of the lens. So why vertex distance is important? Because when a plus lens is moved closer, the effective power decreases. And also when a minus power is moved closer, the effective power increases. That means if the patient is shifting from spectacle to contact lenses and the refractive error is greater than 4 diopter, this vertex distance should be calculated. And if a patient is having a higher amount of refractive error, greater than 7 or 8 diopter, in those cases also, vertex distance should be considered. And ideal vertex distance should be around 12 mm. So this is the example of how a spectacle prescription should be. Like the name of the patient, age, and the male or female, and MRD number which is available, and the distance prescription and the near vision as patient based on the patient's need, and the what type of lenses the patient accepts, single vision, bifocal, or progressives, or any kind of prism corrections or any coatings or photochromics is needed, and special instructions if anything want to be mentioned in this slide. So let's go for the poll. Like a 58 years old male computer professional working at a distance of 50 centimeter and noticing blur while using computer. So let's find out the power needed for that particular working distance. So I think the poll would be started by now. So try to answer the question. Like a 55 years old male, his current working distance is 50 centimeter. So how much of add power would be needed for the patient to actively work at that specified working distance? Yes. 2 diopter, that's the correct answer. That means the reciprocal of the 50 centimeter, that's the add we needed. So 100 by 50, 2 diopter. 2 diopter is the right answer. So, well, in conclusion, it was said that different types of refractive errors requires different prescribing consideration. So we should always carefully monitor based on their need and the specific occupation to give the maximum visual comfort. Thank you.